That's a great question. To even take it a step back a little further, we know that with alloimmunization in general, with the traditional monitoring and the workflow that was done, there was quite a few challenges for everybody. These challenges were for patients, for obstetricians, for maternal fetal medicine physicians, and really what this challenge really essentially stemmed from was really the inability to reliably determine what was going on with the fetal red blood cell antigen status early in pregnancy. So, as a result of this obvious, if you will, a gap in traditional pregnancy care and management, we initially, uh, prior to this expanded launch, launched 6 red blood cell antigens back in 2022. And the initial launch was really centered around doing the red blood cell antigens that can cause hemolytic disease of the fetus and newborn. And we did testing initially on the four most common causes, which also happened to be the four most severe. And so then to answer your question, that was the initial um, clinical challenge that we sought out to solve. But what happened after that was we had so much feedback from nurse practitioners, midwives, obstetricians, and even maternal fetal medicine physicians that it's fantastic that you were able to do these 6 red blood cell antigens because it's really cut down on what we have to do as a result. Can you do more? And so listening to providers and realizing that we wanted to and could address the innovation gap here for this monitoring is why we went from 6 red blood cell antigens with the initial launch to the 16 that were recently expanded to and launched at the Society of Maternal Fetal Medicine or SMFM meeting in Las Vegas. And these 16 red blood cell antigens account for about 99% of the cases or causes, if you will, of the hemolytic disease of the fetus and newborn. The Unity are the name of our prenatal products. So when we're talking about Unity fetal antigens, we haven't talked about platelet antigens, but they're all on the assay as add-ons to the Unity aneuploidy assay. So they're not standalone products because we're not doing that as of right now. So really, we would advise using the Unity aneuploidy assay as a first-line product. So therefore, if things like antibodies are identified on routine antibody screen in pregnancy, they can then add on the red blood cell antigen, and in select cases, we're the only first and only folks that do the platelet fetal antigens. We can do that as well. So really, it's more a validation, if you will, of our initial Unity aneuploidy assay, which, by the way, that information and the numbers have been published in peer-reviewed journal articles, as have the red blood cell antigens that we previously launched with. So this has been published extensively in the literature, validating not only our aneuploidy assay, but the fetal antigens that have come as a result of that as well. Basically, the innovation with the fetal antigen testing, as I said, stemmed primarily because there was clinical gaps in traditional pregnancy management in this arena. What we have traditionally done, because we never knew what the fetal red blood cell antigen status was. Okay, we never have traditionally known that. The way we monitored pregnancies is we would do, maternal antibody titers on a frequent basis. We would then have to send patients to maternal fetal medicines as far as referrals because we assumed pregnancies may be at risk, and therefore many times we would have to do a serial ultrasound evaluation of the fetal middle cerebral artery peak systolic velocity Dopplers. So said more simply, when we didn't know what the fetal red blood cell antigen status was, we would do a lot of extra monitoring and testing with maternal antibody titers and middle cerebral artery Doppler waveforms in pregnancies. Obviously, this is a lot of utilization of resources. It can be anxiety provoking to patients and really changes the workflow in both OBGYN and maternal fetal medicine practices. So, therefore, the premise of trying to solve this gap in traditional pregnancy monitoring was that. So, as a result, now we can determine the fetal red blood cell antigen status. And like I said, for the launch, up to 16 of those when we're talking about the red blood cell antigen as early as 9 weeks of gestational age. And the reason that's so massively important is now when we know that fetuses are antigen negative and therefore really not at risk for hemolytic disease of the fetus and newborn, then all of the extra surveillance that I just spoke to you about, monitoring monthly or at least monthly maternal antibody titers and very frequent Doppler waveform assessments, usually with the referral to maternal fetal medicine, don't have to occur. And as a result of much of the work that was done and the publications that we will send to you, experts in the field actually put out in JAMA, it's called the JAMA Network Guidelines, and we'll send this as well in November of 2025, and really recommended a practice guideline that when these fetuses early on, like I said, as early as 9 weeks, are found to be antigen negative for the red blood cell that we're talking about, no further surveillance will be needed for the rest of the pregnancy at that point in time. So it's really a major practice changing guideline. But more importantly than anything, yes, it's changing for obstetricians because maybe they then don't have to refer those out to maternal fetal medicine. It's changing for maternal fetal medicine physicians because they may not have to do all that heightened surveillance and whatnot. But most importantly, it's best for the patients and their family because in a situation where there's a high degree of anxiety and uncertainty, we can reassure the vast majority of patients very early on that there's nothing to worry about, and all of this extra surveillance is not warranted or required. And that's really been, backed up by that JAMA network practice guideline update that recently came out.